Thank you, Dr. Himpe. Fluid strategy in traumatic brain injury. And of course, I want to thank the organizers also for inviting me. At first sight, it looks so easily. Traumatic brain injury causes primary injury, which is physical damage to the parenchyma during the insult, and then secondary injury in which edema takes part of it. And if you go to the Webster's dictionary, edema is an abnormal collection of watery fluid in a bodily tissue or cavity. It looks so easy. We all were taught about the Mondry-Kelly principle, that ICP and edema determine outcome, that the cranium is a fixed fold, and that brain parenchyma has 80% of water, so brain volume is corresponsive to changes in water content. So it seems easy again. So if your brain is precious, and if you take these physiological principles into account, we should just keep it dry. But we are actually completely confused, like the previous speaker already introduced, which and how much fluid we should give in traumatic brain injury. And if you go again to the Webster's dictionary about confusion, it's a situation in which people are uncertain about what to do or are unable to understand something clearly. The feeling that you have when you do not understand what is happening, what is expected. The act of mistakenly thinking, I still have 20 minutes, I hope, right? The act of mistakenly thinking that one person or thing is another, and a state or situation in which many things are happening in a way that is not controlled or orderly. And I'm going to try to demonstrate you in the next 18 minutes that that is true for fluids in traumatic brain injury. 2, because sitting at the bedside of a patient with TBI, we have until now actually a little bit forgotten a second basic of the physiopathology, which is the blood-brain barrier, with a very difficult formula behind it. Until recently, it was not known that if you give hyperosmolaric agents in the peripheral circulation, whether it really enters into the brain. This small but elegant study shows that if you raise the serum osmolarity into the peripheral circulation, you also raises the CSF osmolarity per kilogram, which clearly indicates that that blood-brain barrier in the daily practice also is broken down. Because what happens in our traumatic brain injury patients? First of all, hypotension, lower than 65 millimeters of mercury mean arterial pressure, occurs up to 73% during the ICU stay. And it's one of the most important independent predictors of severe outcome, almost doubling mortality. Hypovolemia and hypoosmolarity by themselves worsen brain edema, and even hypoalbuminemia, which has been shown in sepsis patients to be an independent predictor of worse outcome, is that too in our traumatic brain injury, unless otherwise believed. And the third point is, and we all know that, is that mystic of autoregulation, which is difficult to measure at the bedside, but shows us that we should regulate the blood pressure and therefore the perfusion in a totally different way in patients with traumatic brain injury. Yes, we are confused. A situation in which people are uncertain about what to do or are unable to understand something clearly. One of the most striking trials, actually, of recent years is one in the New England Journal of Medicine showing that intracranial pressure monitoring in patients with traumatic brain injury makes actually no difference as opposed to standard non-monitored therapy. And although it was done in Southern America and there were much criticism about it, and the patients who did not receive an ICP monitoring device got a better standard treatment than the other ones, they will look better than the ICP monitor done. This has struck a lot, because this means that things that we are doing for 20 or 30 years are not that obvious as we always believe. In all guidelines, we should give aggressive fluid administration. and guided by CVD or cardiac output or whatever you want, or monitored by extravascular lung water or pulmonary capillary wedge pressure. We should not be too restricted, taking this principle to keep the brain dry into account. Although in some trials, excessive and inappropriate fluid in traumatic brain injury has caused fluid overload and ARDS, large amounts of fluids are usually administered in large amounts in most TBI patients all over the world. Which fluids should we use? Crystalloid-based fluid strategies are favored, and as said by the previous speaker, nowadays more balanced crystalloid fluids than just sodium chloride. But the evidence in brain injury actually is limited, and it's a pragmatic approach to resuscitation. Confusion is the act of mistakenly thinking that one person or thing is another. We all know that hyperglycemia is bad, and even in patients with traumatic brain injury, we try to give insulin from time to time to lower the target. And usually we don't infuse pure glucose 5% in a patient with traumatic brain injury. Such a limited hypo-oncotic fluid is not nowadays used. But do we think daily that glucose is actually the sole energy for brain cells? There is no other energy. And recent elegant studies have shown that glucose administration in rats, for instance, and I know a human is not a rat, but even we might cause neuroprotection in the cortex and the hippocampus and improve cerebral metabolism. So eventually not too much, but also not too restricted in glucose administration. Oh yes, we know that lactate is bad, and especially that lactate clearance might guide our prognosis. And it's a waste product of anaerobic metabolism. But lactate by itself is elegantly used as an alternative fuel in the brain. And in a paper in Journal of Neurotrauma, a paper ahead of print of this week, lactate uptake in the brain was associated in patients with traumatic brain injury with a higher IV difference in glucose values. And hyperosmolar sodium lactate actually can decrease ICP. And in a beautiful study in intensive care of recently, half more sodium lactate infusion prevents intracranial hypertensive episodes in severe traumatic brain injury, because if you compare, which is shown here, actually classical crystalloids with somewhere in between lactate osmolar products, you get less periods of high intracranial pressure, and you get less problems with electrolytes. Confusion is a situation in which people are uncertain about what to do or unable to understand something clearly. The trial on fluid administration in traumatic brain injury, which struck us the most, was actually related to the SAFE trial. First, people compared albumin and saline for fluid resuscitation in the intensive care unit. And as you all know, in this beautiful paper in the New England Journal of Medicine, there was no change in survival whether you used albumin or saline. Again, saline. And what do people then do when they don't find statistical significance? They do a post hoc analysis because they want the next paper in the New England Journal of Medicine. And then they take out the subtypes of traumatic brain injury. Although usually this is not the most favorable statistical method, it gives us some clues. And in this sub-analysis, you see the opposite. You see that those patients with traumatic brain injury, a few hundreds, which were treated by albumin, had a worse outcome than those with saline. Why does it occur? Why, if hypoalbuminemia by itself is a predictor of a worse outcome, why administering albumin by itself doesn't improve outcome in traumatic brain injury? We don't know it, but again, a trial in press at the moment, 321 patients, 164 with albumin and 157 with saline. Saline again. The use of albumin was associated with a linear increase, so relative related to the amount of albumin you give over time in mean ICP. Perhaps it's just that simple. Can we use, as suggested by the previous speaker, hypertonic or hyperosmolar solutions? Mannitol causes ICP decrease by the elimination of water, targeted at a certain osmolarity, as long as you compensate that by adequate fluid replacement. But the problem list is long. It can cause a reverse osmotic shift and even raising brain osmolarity, and as shown a few slides ago, an increase in osmolarity into the cerebrospinal fluids. Hypertonic saline increases salt, expands elegantly intravascular volume, and improves rheology. And actually every possible animal experiment, it's elegantly shown that hypertonic or hyperosmolar solution improve inflammation in traumatic brain injury, especially by preventing the adherence of neutrophils to the endothelium. So why not use? And is hypertonic better than mannitol? As already suggested by the previous speaker, we don't know it actually. Oh yes, and then you do meta-analysis, and the Cochrane is discussing about it, and there should be a little bit more favorable for hypertonic saline than mannitol. But if you are really honest, there are no large trials, randomized, that try with a goal to obtain a certain osmolaric state in the peripheral blood to really demonstrate that this favors outcome. And this lack of scientific evidence leads to very heterogeneous practice patterns in the beautiful paper of 2011. Many even do not prefer mannitol because they don't believe in it. Otherwise, use it more as a more effective way. But really, the belief in the general ICU population to repetitively use especially mannitol is at this moment lacking. Confusion means the act of mistakenly thinking that one person or thing is another. Why, dear colleagues, don't we know it for the moment what we really should use? 5 reasons. First, we have not listened to nature. If you look to all the papers on the pathophysiology of the breakdown of the blood barrier, in all of them, and this is only a simple drawing, albumin is actually expressed at a high level, probably trapped at the blood-brain barrier. And the combination of TGF-beta, one of those 7,236 different cytokines which are expressed in traumatic brain injury, together with albumin, are increased. If we know that, it's not surprising that giving albumin might worse outcome, because by itself, it increases the blood-brain barrier dysfunction. 2, until now we have used the wrong endpoints, because in that SAFE trial, we have evaluated albumin directed to hemodynamic and resuscitation endpoints, but not to the possible benefits of maintaining serum albumin at a constant level, hyperosmolarity for instance, during ongoing trial. Hyperosmolar agents remove fluting from the remaining normal brain tissue, even more than from the damaged brain tissue, and that's something which we don't want to see. And once hyperosmolarity has been attained in all guidelines, it must be sustained. And how frequently do we do that at the bedside? We give it once or twice, we monitor it, but give we then again that, only guided on the osmolarity? No, in the daily practice, we don't do that. In Houston, we have a problem. Because, already suggested by the previous speaker, there are several products of albumin all over the world present. In Belgium, we usually use 20%, 20 grams per 100 milliliter, but in many trials, albumin 4% has been used, which is, of course, from an osmolaric state, totally different than the 20%. Indeed, in many trials, albumin administration to patients with traumatic brain injury decreases the amount of fluid in the brain and might even in small series improve outcome, which is totally not the same as we've seen in the SAFE trial. And here in albumin 4 versus 20% in a protocol, including albumin administration in combination with a neutral or a slightly negative fluid balance, which is usually not taken into account, was associated in a low mortality rate in patients with TBI in spite of a relatively high frequency of respiratory failure called ARDS. So we have mixed up in all our trials albumin 4% and 20%. And indeed, albumin 4% is a hypoosmolaric solution and not a hyperosmolaric one. And probably that's not what we want in traumatic brain injury. Here is a comparison. So from Professor Van Aken actually, if you see the difference in the osmolarities, you see here that an albumin 4% solution has even a lower osmolarity than a Hartmann solution, which means that we are indeed mixing up everything. This means human albumin, gelatin, and Hartmann solution have a low measured in vitro osmolarity, and if no colloid should be used in patients with TBI, is not supported by this physiological principle, it's rather hypoosmolaric and hypotonic solutions should be avoided. Fourth statement. We have not taken into account that a patient of traumatic brain injury encounters two types of edema. The one is vasogenic edema, caused by the breakdown of the blood-brain barrier along white matter tracts at the place of contusion, inflammation, and in the subacute phase of cerebral infarction, but this is not the contents of my talk. And cytotoxic edema, ischemia, is encountered when cellular swelling is seen in a hyperacute ischemic infarction, and when infarctions occur on top of traumatic brain injury, as well in the gray as in the white matter. But on a daily basis, at the bedside of a patient, we are not able to distinguish this vasogenic and cytotoxic edema on a single scan or MRI or in the treatment. And last but not least, we do not use in all our patients a quantitative imaging assessment of the blood-brain barrier. Oh yes, we can go to perfusion CT, we say that a lot, but not everything about the blood-brain barrier. We can go to the MRI, but in our unit, in certain subunits, the nurses point to the wall that frequently we go to the MRI. We can go with a patient with traumatic brain injury every 6 or 12 hours to the MRI. That is not from a practical point of view seen. Or we monitor too less with difficult monitoring techniques what really happens at the brain parenchyma. So, dear colleagues, we are at the moment completely confused. Because on one side, we want to keep the brain dry, because that might be precious. On the other hand, we want to try to perfuse it. So if you look to the literature about all the fluids in traumatic brain injury, we are completely confused. Because we are uncertain what to do, we have the feeling that we do not understand what is really happening. We are in a state or situation where many things are happening in a way that is not controlled by our daily monitoring, and we act mistakenly thinking that one person or thing is another, but it isn't. What are the current guidelines? Soon after the SAFE trial, the European organization made a consensus statement on colloid volume therapy as interpreted by the respective ECM task force from not to use it anymore in traumatic brain injury deliberately. No colloids should be used in patients with head injury. The recommendations in the New England Journal of Medicine on fluids recently elegantly state again that saline or isotonic crystalloids are indicated in patients with traumatic brain injury, and as clearly indicated by the previous speaker, it should be more isotonic balanced crystalloids rather than saline by itself. And albumin is not indicated in patients with traumatic brain injury. It should just take that simple physiopathology into account of the breakdown of the blood-brain barrier. So to come to a conclusion, dear colleagues, large amount of fluids can be used in traumatic brain injury because perfusion should be achieved. Colloid should be used with caution or even not in most patients with traumatic brain injury. Albumin, probably you can throw it away in those circumstances until further evidence. Avoid hypotonic solutions, but do not restrict your glucose to 0 because your brain needs it. And this, ladies and gentlemen, leads to much confusion at the bedside. I wish you a good evening.